So good evening, everyone. How are we doing today? We're so glad that you have joined us today to listen to this discussion on diabetic kidney disease. And you know that you've made your health your priority and are going to take time to listen to this. I'm your host, Aparna Mittal, and I'm founder of Patients Engage. Before I introduce our experts today, let me quickly introduce Patients Engage. Patients Engage is an organization that has been operational for over 5 years. We are essentially a digital platform focused on evidence-based and holistic management of chronic conditions from the perspective of patients and family caregivers. We believe in the value of lived experiences and strongly urge each and every one of us to be better informed and proactive about managing health and chronic conditions in order to improve the quality of life. We've been running a series of webinars in our effort to allow the ordinary citizens to interact with healthcare professionals and persons with lived experiences. So today we have with us an interesting panel. We have been doing we started a series on diabetic kidney disease. Today is the second of that series. And one of the things that I think people with diabetes need to be aware of is that almost 40% of persons with diabetes get diabetic kidney disease, but it can be prevented. And if you already have it, it needs to be managed. So today we have with us two specialists, Dr. Rohit Rungta, consultant nephrologist at Medica Superspecialty Hospital in Kolkata, and Dr. S.K. Hammadur Rahaman. He's an endocrinologist and consultant diabetologist, again from Medica Superspecialty Hospital. And my co-moderator with me is Moina, who will support me in running this webinar, especially on the Bengali aspect. So this session will be in a mix of Bengali and English. As per our agenda, we will understand what is diabetic kidney disease, look at the causes, risk factors, symptoms of diabetic kidney disease, understand the relationship between diabetes, hypertension, and diabetic kidney disease prevention, best practices of management, and also look at what are the changes in management that you need to do if you are COVID positive, and any other questions that you have to ask. As always, guidance to our attendees. The information discussed here does not replace a medical consultation. So while we go into fair amount of detail, it is not specific to an individual. So you please do consult the doctors separately for specific medical issues. This session is being recorded. If you are logged into Zoom, you can post your questions in the Q&A button at the bottom. And if you are on Facebook, you can post them on the live feed. Um, as always, you can write into us at editor@patientsengage.com and follow us on our website, patientsengage.com, our Facebook, Twitter, YouTube handle, or you can even download our app. All of these sessions that get recorded, our series of webinars, do go up on our YouTube page. So let me stop sharing and start the discussion. So our first question, thank you once again, Dr. Rungta and Dr. Rahaman for joining. First,
Please.
yeah. First question to you, Dr. Rungta, is what is diabetic kidney disease?
Right, ma'am. So as we have already said, not all patients of diabetes develop diabetic kidney disease. More or less around 40% of the patients who have diabetes will develop diabetic kidney disease in long run. So when I say diabetic kidney disease, I mean that the diabetes is a cause of the kidney problem that have initiated in a person who is a diabetic. This diabetic kidney disease usually develops after 10 to 15 years of diabetes from the time of diagnosis, usually in type 1, which is usually diagnosed much earlier as compared to type 2, which remains indolent for a very long period of time. And the usual presentation of diabetes type 2 and type 1 are quite different, quite varied. The classical teaching has been that type 1 diabetes develops in younger individuals and type 2 is usually in the older age, say 40, 50, and 60. However, the scenario is changing, and we are now getting, Dr. Rahman would be better able to tell this, but we are now getting more and more patients in the middle age group who are having diabetes type 2. So, limiting my talk to diabetic kidney disease usually develops once a patient develop diabetes and it persists for say around 10 to 15 years. The first symptom of diabetic kidney disease, I would say, is proteinuria. What we ask the patient is frothy urine, foamy urine is one of the foremost indicator of development of diabetic kidney disease. Limited to the kidney, the only test, the only investigation that we have is serum creatinine level, which usually foresees how the kidneys are functioning. However, I would like to point out here that kidney function deteriorates quite later on. The patient develops proteinuria much, much earlier as compared to the rise in creatinine. So, pertinent to the development of diabetic kidney disease is a regular follow-up with an endocrinologist, a regular follow-up with a nephrologist to see if he or she is having this proteinuria. So this is the stage at which the diabetic kidney disease can be prevented, can be halted, can
Right.
be regressed actually with medicines, with holistic approach, with controlling diabetes, with controlling blood pressure, and with few medicines that we have that that can retard the progression of the proteinuria. I would just like to point out one thing. We often use two terms, diabetic kidney disease and diabetic nephropathy, synonymously. So, classically, diabetic kidney disease is the clinical diagnosis, what we see from the reports, what we see from the symptoms. And diabetic nephropathy is the diagnosis, is the histopathological diagnosis. So once we do a kidney biopsy, we can only stamp that as diabetic nephropathy, the changes inside the kidney. However, diabetic kidney disease is only clinical. Once we see the symptoms, once we see the proteinuria, once we see the other parameters of diabetes and the other problems that the patient is having, we can stamp it as diabetic kidney disease.
Right.
Right, ma'am.
Just one clarification on that. Is there a difference between chronic kidney disease and diabetic kidney disease?
Yes. So that's a good question because diabetic kidney disease is actually a forerunner of CKD, chronic kidney disease. So once a patient develops diabetic kidney disease, he might land up into chronic kidney disease. So as I said, once we measure the creatinine levels, the blood creatinine levels, the serum creatinine levels, and by definition, a patient is stamped as CKD. One is, diagnosed as CKD if the creatinine is persistently high for last 3 months.
Mm,
So that can be because of the any cause. One of the causes is diabetes. Yes, in the Indian subcontinent, diabetes is one of the most common causes of chronic kidney disease, CKD.
right. Thank you. But there can be other causes as well, right?
Exactly.
So,
Exactly.
yeah. Dr. Rahman, what are the risk factors? I think Dr. Rungta said that some of the symptoms to watch out for and that there needs to be regular monitoring. But what are the risk factors typically for diabetic kidney disease?
This is important question in relation. If we want to prevent diabetic kidney disease, we have to know what are the risk factors. We can classify these risk factors as modifiable and non-modifiable. The most important risk factor for diabetic kidney disease is the glycemic control, glucose control, simply. And the longer the duration of diabetes, greater the risk of having diabetic kidney disease. And it's the poorer control of diabetes, poor glycosylated hemoglobin, poor higher HbA1c for longer duration will lead to diabetic kidney disease. So one important is glycemic control. Poorer the glycemic control, higher is the risk of developing diabetic kidney disease. Number one. Number two is hypertension. In type 1 diabetes, we don't see hypertension so much, but for type 2 diabetes, we often see other comorbidities like hypertension, dyslipidemia. This hypertension is the second risk factor for this diabetic kidney disease. A diabetic subject who is not having hypertension, the risk is low. But when a diabetic subject develops hypertension simultaneously, the risk is higher. And if we see the natural history of diabetic kidney disease, once a diabetic subject develops proteinuria, Dr. Rungta rightly pointed out, it's a microalbuminuria, then macroalbuminuria. Once a diabetic subject develops macroalbuminuria, then the blood pressure start rising. And both this diabetes and blood pressure leads to acceleration of this diabetic kidney disease. The third important risk factor is dyslipidemia. Type 2 diabetic subjects, they are also at risk of having dyslipidemia. So this dyslipidemia is a third risk factor. Fourth risk factor is smoking. Smoking we often do, and we neglect on this part. We go for treatment for diabetes, blood pressure, and cholesterol treatment, but we don't quit smoking. So this smoking is a fourth risk factor which can be modified. And there are certain non-modifiable risk factors like genetic risk factors, family history of diabetic kidney disease, and certain other risk factors are there. So we should detect these risk factors early and have to control these risk factors to retard or to halt the progression of diabetic kidney disease.
Thank you, Doctor. I think actually I would go back to you, Dr. Rungta, to kind of quickly summarize what you had earlier said in Bengali, so that we get the Bengali audience as well.
Right.
So just very quickly, the key points on diabetic kidney disease.
Right. So diabetic kidney disease je bola hoy, that is seen in patients. ওটা দেখা যায় যে পেশেন্টরা ডায়াবেটিক আছেন অনেক দিন ধরে। নর্মালি যে কিডনি নষ্ট হওয়া স্টার্ট হয়, কিডনি যে এফেক্ট হওয়া স্টার্ট হয়, দ্যাট ইজ ইউজুয়ালি আফটার 10 to 15 ইয়ার্স। তো ওটা অনেক স্টেজের মধ্যে যায়, যেমন ডক্টর রাহমান বলছিলেন আগে মাইক্রো অ্যালবুমিনুরিয়া, মাইক্রো প্রোটিন হয়, তারপরে ম্যাক্রো প্রোটিন হয়, অ্যান্ড দেন দ্য পেশেন্ট ল্যান্ডস আপ ইনটু ডায়াবেটিক কিডনি ডিজিজ। তো ডায়াবেটিক কিডনি ডিজিজ যে আছে ওটা একটা ফার্স্ট সিমটম বেসিক্যালি সিকেডি ডেভেলপ হওয়ার জন্য। সিকেডি যে আমরা বলি দ্যাট ইজ ক্রনিক কিডনি ডিজিজ, যখন কিডনিটা নষ্ট হয়ে গেছে আর ওটা ভালো করা যাবে না। তো হোয়াট উই ক্যান ডু ইজ ওটা আমরা প্রিভেন্ট করতে পারি, একটা জায়গায় হল্ট রাখতে পারি কিডনি প্রবলেমটা। বাট ইউজুয়ালি দ্য ড্যামেজ যেটা অলরেডি হয়ে গেছে ওটা আবার রিভার্ট ব্যাক করা যাবে না, আমরা ওটা হল্ট করে রাখতে পারি। তো ওর জন্য মেইন ইম্পর্টেন্ট আছে ডায়াবেটিস কন্ট্রোল, হাইপারটেনশন কন্ট্রোল, স্মোকিং, dyslipidemia, Dr. Rahaman বলেছে। আমি জাস্ট একটা অ্যাড করছি, ওবেসিটি, right? Obesity is an important risk factor nowadays for in patients who develop diabetic nephropathy, diabetic kidney disease. So most of the patients এখন যে আছে অনেক obese, westernization of diet, আমাদের dietary habits অনেক চেঞ্জ হয়ে গেছে। তো কত পেশেন্ট আমরা দেখি যে ডায়াবেটিক আছেন, আর্লি ডায়াবেটিস হচ্ছে, younger populations are getting diabetic, and over a long period of time, say suppose a patient একটা ডায়াগনোস হয়েছে 30 বছরে ডায়াবেটিস, 10 বছর পরে 15 বছর পরে এটা শিওর আছে কি উনি ডায়াবেটিক কিডনি ডিজিজ হতে পারে। তো ওই পেশেন্টদের ক্ষেত্রে যদি উনি ওবিজ আছেন, আমরা ওয়েট লস করতে পারি, এটা অনেক প্রিভেন্ট করে, ডায়াবেটিক কিডনি ডিজিজটা প্রিভেন্ট করে। তো ডায়াবেটিক কিডনি ডিজিজ যে বলা হয় দ্যাট ইজ বেসিক্যালি প্রোটিন আসার স্টার্ট হয় কিডনি থেকে। তো কিডনির ভিতরে কিছু চেঞ্জেস হয় দ্যাট লিডস টু প্রোটিনুরিয়া, যে আমরা বলি ফোমি ইউরিন, না পেছাবে ফেনা হচ্ছে, পেশেন্ট কতবার পেশেন্ট এসেই বলে কি পেছাবে ফেনা হচ্ছে। তো ওই সময় যদি আমরা চেক করি, ইউরিন রুটিনটা চেক করা হয়, ক্রিয়াটিনটা চেক করা হয়, এইসব যদি গন্ডগোল থাকে, দেন we classify them as diabetic kidney disease.
Thank you. And Dr. Rahaman, if you can also, if there's anything else you want to summarize your points as well.
Yes, ma'am. আমার কোশ্চেনটা ছিল যে কি কি রিস্ক ফ্যাক্টরের জন্য ডায়াবেটিক কিডনি ডিজিজ হয় এবং আমরা কি করে প্রিভেন্ট করতে পারি ডায়াবেটিক কিডনি ডিজিজ। তো এটা খুব গুরুত্বপূর্ণ এই সেন্সে যে আমরা যদি রিস্ক ফ্যাক্টরগুলোকে আইডেন্টিফাই করতে পারি, তাহলে আমরা ডায়াবেটিক কিডনি ডিজিজটাকে হল্ট করতে পারবো বা তার প্রোগ্রেশনটাকে আমরা কম করতে পারবো, রিটার্ড করতে পারবো। তো যেগুলো ইম্পর্টেন্ট রিস্ক ফ্যাক্টর সেটা হচ্ছে যে গ্লুকোজ কন্ট্রোল যদি কাউরির খুব ভালো থাকে তাহলে ডায়াবেটিক কিডনি ডিজিজ হওয়ার সম্ভাবনা কম। আরেকটা ইম্পর্টেন্ট রিস্ক ফ্যাক্টর হচ্ছে ডিউরেশন অফ ডায়াবেটিস, কত বছর ধরে কাউরির ডায়াবেটিস আছে। কোনো ব্যক্তি যদি অনেক বেশি বছর ধরে ডায়াবেটিসের রোগী হন, তার ডায়াবেটিক কিডনি ডিজিজ হওয়ার সম্ভাবনাটা অনেক বেশি ইন কম্পারিজন টু যার ডায়াবেটিসটা অল্প দিনের রয়েছে। 2 নম্বর হচ্ছে ব্লাড প্রেশার কন্ট্রোলটাও খুব গুরুত্বপূর্ণ। ব্লাড প্রেশার কন্ট্রোল যদি না থাকে, ডায়াবেটিক কিডনি ডিজিজের প্রোগ্রেশনটা খুব বেশি হয় এবং খুব তাড়াতাড়ি হয়, অ্যাক্সেলারেশন হয়। ইনফ্যাক্ট ডায়াবেটিক কিডনি ডিজিজ যখন শুরু হয়, যখন মাইক্রো অ্যালবুমিনুরিয়া থেকে ম্যাক্রো অ্যালবুমিনুরিয়ায় পৌঁছায়, তখন ব্লাড প্রেশারটা খুব শার্পলি রাইজ করে এবং প্রোগ্রেসিভলি রাইজ করে। তো ডায়াবেটিক কিডনি ডিজিজ পেশেন্টদের ক্ষেত্রে আমাদের ব্লাড প্রেশার টার্গেট একটু নিচের দিকে, ইট ইজ 125/75, একটু অন্যান্য পেশেন্টদের তুলনায়। তো সেটাকে ব্লাড প্রেশার যদি আমরা কন্ট্রোল করতে পারি তাহলে ডায়াবেটিক কিডনি ডিজিজের প্রোগ্রেশনটাকেও আমরা কম করতে পারি। 3 নম্বর ইম্পর্টেন্ট রিস্ক ফ্যাক্টর হচ্ছে কোলেস্টেরল প্রবলেম। যদি কোলেস্টেরল প্রবলেমটাকে আমরা কন্ট্রোল করতে পারি তাহলেও আমরা প্রোগ্রেশনটাকে রিটার্ড করতে পারি। নাম্বার 4 ইজ স্মোকিং সেসেশন, যে আমরা স্মোকিংকে কুইট করতে হবে, তাহলে আমরা ডায়াবেটিক কিডনি ডিজিজ প্রোগ্রেশনটাকে আমরা রুখে দিতে পারবো। আর ফিফথ ইম্পর্টেন্ট পয়েন্ট ডক্টর রুংটা পয়েন্ট আউট করেছেন, ওবেসিটি কন্ট্রোল। অ্যাকচুয়ালি দিস ওবেসিটি, ব্লাড প্রেশার, ডায়াবেটিস, হাইপারটেনশন আর বেসিক্যালি ফ্রুটস অফ দ্য সেম ট্রি, একই গাছে সবগুলোই ফলে। তো বেসিক্যালি সাইমালটেনিয়াসলি আমাদের মাল্টিপ্রং অ্যাপ্রোচ করে ডায়াবেটিস, ব্লাড প্রেশার, কোলেস্টেরল, হাইপারটেনশন কন্ট্রোল করতে হবে যাতে করে আমরা কিডনি ডিজিজকে প্রিভেন্ট করতে পারি। কিছু নন মডিফায়েবল কারণ রয়েছে, যে জেনেটিক কারণ বা ফ্যামিলিতে কারোর আছে কি না সেগুলোকে আমাদের দেখতে হবে। আরো দুটো ইম্পর্টেন্ট কারণ হচ্ছে ইউরিক অ্যাসিড প্রবলেম আর অবস্ট্রাকটিভ ইউরোপ্যাথি আমরা বলি, সেগুলো প্রিভেন্টেবল কজ। আমরা ডায়াবেটিস পেশেন্ট কিডনি ডিসফাংশন মানে আমরা চোখ বন্ধ করে বসে থাকবো না যে এটা ডায়াবেটিসের জন্যই হচ্ছে, আমাদেরকে অন্যান্য মডিফাইবল কারণ দেখতে হবে, যে ওই ব্যক্তির ইউরিক অ্যাসিড প্রবলেম আছে কিনা, প্রস্টেট রিলেটেড প্রবলেম আছে কিনা, বা কোনো স্টোনস আছে কিনা, কিডনি স্টোনস লিডিং টু কিডনি ডিজিজ, এগুলোকেও আমাদেরকে দেখতে হবে। আমাদের আইসটাকে ওপেন রাখতে হবে যে শুধু ডায়াবেটিস রোগী, ডায়াবেটিস না অন্যান্য কারণও থাকতে পারে।
Okay. Next question is, I have diabetes and hypertension. What can I do to prevent diabetes kidney disease? Dr. Rahman.
Yes, ma'am. If I have diabetes and hypertension, my first approach will be to control diabetes first. Very tight control I want to have. This HbA1c target will be 6.5 to 7 or maximum 7.5. This is number one. Number two, I should have good blood pressure control. I should have regular monitoring of blood pressure. There is, we see in studies that there is loss of nocturnal dip of blood pressure in hypertensive subjects. So blood pressure monitoring, if possible, ambulatory blood pressure monitoring and nocturnal blood pressure monitoring, if required, then we have to do. We often check once or twice a day in the morning and evening. That may not be sufficient. So we may need to check this blood pressure, this ambulatory blood pressure monitoring we may need. Number three, we have to quit smoking. If we smoke, we have to control this cholesterol issues. If uric acid problem is there, then uric acid have to be under control. And exercise, we should have regular exercise. We should reduce or cut down our obesity part. So if we can address these issues, then we will be all right in the long run.
Right. Thank you. The next on the okay. So often people monitor blood sugars but not the blood pressure. If you can talk, both of you, if you can talk about the impact of hypertension on persons with diabetes. Maybe Dr. Rungta, you can start first.
So as Dr. Rahaman pointed out earlier, type 1 diabetes usually don't have blood pressure at the time of diagnosis, right? So it's more of a chronic problem. Patient develops hypertension in type 1 diabetes much later on. The scenario is completely different in type 2 diabetes, which is the most common. Majority of the patient suffers from type 2 diabetes, and at the time of diagnosis, most of the diabetic population also have hypertension, right? So both these needs to be controlled simultaneously. So it's not one or the either, it's actually both together. So once we are controlling sugar levels of the patient, it's pertinent to check his blood pressure at every follow-up, and it has to be controlled. It has to be the recommended blood pressure control is say around 130/70, 130/80 kind of thing. Most of the studies have shown that a strict blood pressure control along with a blood sugar control usually halts the development of diabetic kidney disease and CKD as well. So the more stricter the blood pressure control is there, the more stricter the sugar control is there, the less chances are there that the patient will develop diabetic kidney disease or other complications.
Right. Dr. Rahman, anything else that you would want to add?
I agree, Dr. Rungta. What I additionally want to add is that As we classify this diabetic nephropathy, if you see the stages, then from first normal stage, then microalbuminuria, then macroalbuminuria, then rise of creatinine. If you see these stages, it is hyperglycemia which is important for this microproteinuria, then macroproteinuria, and simultaneously blood pressure can also cause this microproteinuria and macroproteinuria. So obviously, if both these factors are there, then progression will be faster. There will be acceleration towards the end stage of the renal disease. So that's why both factors to be controlled simultaneously.
Right. So if you typically, I think you said that it is about 15 to 17 years, right? Is the typical time after you get diabetes to get DKD. If you manage it well, how much can you delay it? Is there any guidelines on that?
We know up to 40% of subjects of diabetes will develop diabetic kidney disease. So rest 60% will not develop. So
Hmm.
if we can have a good control of blood sugar, good control of blood pressure and cholesterol level, if we can cut down the obesity, if you do regular exercise and have proper diet, then we may defer it indefinitely.
Right. Okay. Thank you. Um, so once I develop, I've been managing my diabetes, but now I have diabetes kidney disease. So is there any change in the way I manage my diabetes? Do I need to manage my HbA1c at different levels? Is there any changes that I need to bring in my approach to managing?
Definitely. If I am a diabetic subject, I develop diabetic kidney disease in the form of microalbuminuria, then definitely I have to be alert and I have to have very good glycemic control, very good blood pressure control. And the good part is that this microalbuminuria stage is reversible. If we can have a good control, then we can go back to normal stage. And this is the gratifying of controlling blood sugar and blood pressure. So we should change our approach. We should have a good glycemic control. We should have good blood pressure control. We should have more frequent visit.
Hmm.
And once I am diabetic and having diabetic kidney disease by microalbuminuria or macroalbuminuria, I think before leveling, we should have a repeat urinary albumin creatinine ratio or urinary albumin test, because there are so many factors which can falsely elevate this urinary albumin excretion. So, like poorly controlled diabetes itself will falsely elevate this protein loss. Poorly controlled blood pressure, if the patient is having heart failure, if the patient is having febrile illness, that can also increase this protein loss. So before I level it, a diabetic kidney disease by excretion of protein through urine, I should repeat it in next 2 to 3 months by once or more times to level it diabetic kidney disease. And even if it is because of diabetic kidney disease, then if we can control of these risk factors, glycemic control, blood pressure control, then it may go back to normal stage.
Exactly. Exactly.
Right. Right. Okay.
Okay. So that's the basic charm of treating diabetic kidney disease. In the initial stage, it is completely reversible. So even if the patient develops microalbuminuria, that can be reversed back to the normoalbuminuria, and which can retard the progression of the disease. So I have seen patients who are taking good control of the sugar and the blood pressures, and they have not developed, in spite of having proteinuria, they are perfectly okay for, say, next 15 years, 20 years. And on the other hand, I have seen patients who are not taking good control of themselves, and they'll end up in CKD in, say, 5 years, 4 years, 5 years time.
Okay. Okay.
One more thing I want to add here.
Sure.
You asked me whether we should change our approach to manage this diabetes. Yes, definitely. Even there are some medications came recently in recent few years that can retard this progression of diabetic kidney disease. Like Dr. Rungta will agree with me, like SGLT2 inhibitors or certain gliptins are there which can halt this progression of diabetic kidney disease. Or even SGLT2 inhibitor has data that it can revert back to normal, even from macroproteinuria or stage 3 to stage 2, then normalized.
Right. Thank
Exactly.
you. Okay. Again, a message to our audience who's watching. You can start asking your questions, and we'll take them now. Um, one question I had also was, if you already are doing dialysis, if you, what is the impact of dialysis on blood sugar levels and blood pressure levels, and how should it be managed?
Right. So a patient who is on dialysis, like I would just like to point out one thing here, since suppose a patient of DKD develops chronic kidney disease, what we stamp as chronic kidney disease, and his creatinine is rising steadily. So as he approaches, as he lands up, as he steps up the ladders of CKD staging, say
Mm,
from stage 2 to stage 4 to stage 5, um, his blood sugar levels will be better controlled in spite of taking medicines, right? So most of the patients with stage 4 and stage 5 will require less amount of medications for diabetes as compared to the earlier stages. So
right.
most of the patients feel good that his sugar is controlled and he's now requiring less and less amount of medications.
Mm,
However, on the other hand, this usually signifies that his kidney functions are deteriorating. So coming back to your question, what happens to diabetes when the patient is started on dialysis? So dialysis is actually a modality which keeps the sugar under control because of the various uremic toxins and various metabolic errors that happens in the body. Uh, the cells are almost resistant to insulin, and once the patient lands up in dialysis, we often see that his sugars are quite better controlled. In spite, he doesn't require any medications as well. So this is basically an effect of the dialysis. Once the toxins are being taken out from the body, once his blood is purified, once his blood is removed, the bloods are removed from the toxins are removed from the blood, his sugars are much better controlled. Most of the patients on dialysis usually don't require any anti-diabetic medications. They're seldom on one or two medications to control uh, his blood sugar levels, but
mm,
obviously this is not a rule. you know
right, right. Okay. There's also a question that has come in from a post-transplant patient. He's had transplant in September this year. What is a good HbA1c range for post-transplant type 2 diabetic? Had diabetes before the transplant as well.
right.
Good HbA1c for a post-transplant diabetic subject would be around 6.5 to 7. 6.5 to 7 will be a good target. If we have poor control in the post-transplant patient, then again the transplanted kidney may be at loss, maybe having diabetic kidney disease.
Right,
So we
right.
have seen patients even after transplantation because of poor control of diabetes, that kidney is also not functioning.
Mm,
Again lead to CKD end stage kidney disease and again requiring dialysis. So it would be very much unfortunate for a subject after transplantation to have a poor control and again having CKD.
right, right. Okay.
The very idea of transplantation will be lost actually. The reason why he underwent transplant and post transplant, if he's not controlling his diabetes, the very essence of the idea of getting the transplant is almost lost.
Right.
And I would just like to point out one more point here. Most of the since this patient underwent transplant in September, uh, most of the transplant medicines that the patient receives for keeping his kidney good has a side effect of creating diabetes or hyperglycemia. So if he's getting all the medications and if his blood sugars are not yet controlled, he probably also requires some change in his transplant medicines.
Right. Right. Yeah. So I think that was one of our later questions. Maybe you can talk about explaining steroid-induced diabetes, right? Because they are similar, right, in the transplant medicines. And yeah. So Dr.
Uh,
Rahman.
yes, in post-transplant subject, steroid is very important medicines to suppress the immunity so that the graft is not rejected. But and they require high amount of steroid, maybe prednisolone in the range of 40 milligram, 50 milligram, or 60 milligram per day. And some other medications are also there, like tacrolimus, that can also cause this diabetes in a post-transplant subject. So how this high dose steroid can cause diabetes mellitus? There are different types of steroids and different doses we use for different conditions, not only in these post-transplant subjects. There are so many clinical conditions like rheumatoid arthritis, bronchial asthma, or autoimmune diseases that require this steroid in high doses. This high dose steroid, what it does do, it can act at the pancreas level and it prevents this release and secretion of insulin from pancreatic beta cells. It can cause beta cell loss, beta cell dysfunction. It can cause insulin resistance. There is a term called insulin resistance, which prevents insulin to act at its target level. There is insulin resistance at the level of liver and at the level of peripheral tissues like skeletal muscle and adipose tissue. So this steroid, it acts at the site of liver and creates insulin resistance at liver, causing high glucose output from liver, and it causes insulin resistance at skeletal muscle and adipose tissue, that is fat tissue, causing insulin resistance and prevents uptake of glucose to these sites. So glucose in one hand is getting high output in liver, on the other hand it is not utilized properly. So
Right.
glucose in the blood is very high. It also causes some other issues, like it causes adipose tissue, it causes fatty changes and fat distribution, which also causes insulin resistance, and that leads to diabetes mellitus. And another important factor regarding this steroid, it not only causes diabetes, it also causes certain other diseases like hypertension. It can cause osteoporosis. It can cause cataract. It can cause muscle wasting. So a lot of side effects of steroids are there. If we use steroids in a subject of post-transplant, we should keep our eyes open to see all these side effects, whether happening or not.
Right. Thank you. Thank you, Dr. Rahman.
Mhm.
Uh, Dr. Rungta, we are going through COVID, so let's also talk about a couple of COVID related questions. So, if I have diabetes, diabetic kidney disease, and hypertension, and I get COVID positive, what are my risks and how should I manage it?
Right. So since we are dealing with COVID, scenario, what we have seen, this was not documented earlier, but as we have seen, as we are gaining knowledge about the COVID scenario, we have seen patients getting uncontrolled sugars who are positive. Right?
Hmm.
So I'm not pretty sure about the cause of this, but Dr. Rahman might throw some light upon it. But what we have seen in indoor patients who are COVID positive, they have hayward sugar levels, which was very difficult to control in the initial stages. As we are gaining knowledge about the COVID more and more, we are better able to control the blood sugar levels. Uh, from kidney perspective, I would like to throw some light on the COVID patients who are developing kidney problems, right? So most of the studies till now that has been done on kidney patients, they have shown 15 to 20% of the patients developing proteinuria. Some patients have had hematuria and some patients have AKI, acute kidney injury.
Right.
So that can be because of the various of causes like hypotension, the sepsis that is usually seen with COVID patients. But COVID per se has also been shown to be detrimental for the kidney function. Most of the patients have an increase in the serum creatinine level because of the direct effect of the COVID on the renal epithelium, the renal glomeruli. So, however, a good thing is most of the patients do recover from the AKI once the COVID is negative. And as well as the same goes for the sugar level. So, a person who is COVID positive have uncontrolled blood sugar levels, and once his COVID symptoms subsides, and once he turns out to be COVID negative, probably sugar levels comes under control again.
Hmm. Okay. Okay. Dr. Rahman, would you want to add anything?
Regarding COVID and diabetes, let me talk that this diabetes is not increasing COVID incidence. A subject who is diabetic, he is not having an increased chance of having COVID, number
Hmm.
one.
Hmm.
But if that subject acquires infection, then the rate of complication is much more. Then he may not be he may not be asymptomatic. The chance of having symptomatic disease will be more in a diabetic subject.
Right.
Again, who is symptomatic will require hospitalization more.
Hmm.
Again, if he or she is required hospitalization, may be shifted to ICU. And again, even if in ICU, then may need invasive ventilation. And even those who are on ventilator may be increased mortality because of poor control of diabetes mellitus. And Dr. Rungta wanted to know that why there is so high blood sugar in patients with COVID. In fact, let me be frank. we are going through very tough time to control diabetes mellitus in these subjects. Those who are requiring only 20 or 30 units of insulin before COVID, when they are hospitalized with COVID, they are requiring almost 200 units of insulin.
Exactly.
And we often have to infuse them continuously round the clock, insulin infusion, 10 unit per hour or 15 unit per hour sometimes. And the reasons are multifactorial. This COVID infection, it directly affects the pancreas, the insulin producing organ of our body, and it causes subclinical inflammation at the pancreatic level. So because of that, the insulin release from the body is less. And if it is pancreatitis, then we all know blood sugar goes very high. Number one. Number two, this COVID, as it affects multi-system, it causes a cytokine storm. That is an entity. Cytokine is basically some inflammatory mediators, inflammatory chemicals that is released from the body to tackle with this virus. So there is cytokine tsunami, cytokine storm like situation, which is causing a very high stressful condition for the body, and the blood sugar is going up. Number three is we are using mainly steroids. We just few minutes back, we talked on steroid-induced diabetes. And for these COVID patients, COVID pneumonia, we are using very high dose of steroid, methylprednisolone, very high dose. So this steroid is also causing diabetes mellitus. And the fear of death of these subjects, maybe putting these subjects in increased risk, increased stress, and that is causing hyperglycemia. So it's very difficult to control these subjects' blood sugar level, but we are using this insulin infusion, very high dose of insulin, and simultaneously some other drugs also to control this diabetes mellitus. The good part is that once we are reducing these steroid doses, once the infection is under control, then blood sugar control is absolutely fine.
Okay. So is it recommended, therefore, because of the spikes that happen if you have COVID infection? Is it for, first of all, is it for, does it depend on your viral load? So if you've had a high viral load, is the impact higher? And second is that, do you recommend that all patients, all diabetic patients who get COVID should get hospitalized, or can they manage these spikes in insulin required at home as well?
If a COVID subject acquiring, if a diabetic subject acquiring COVID infection and blood sugar is not under control, I would advise to get him or herself admitted in a hospital to have good glycemic control. If glycemic control is not well, then chance of morbidity and mortality is very high. So that's why my advice will be, if blood sugar is not under control at home, then get oneself admitted in the hospital. Your second question, whether it is related to high COVID load, viral load or not. Definitely, if viral load is higher, then the disease burden will be higher. The person will have multi-system infection, not only in the lungs, but also will be affected in the kidney, pancreas, brain, in the vascular tree. So that patient will have multiple complications like low blood pressure and blah, blah, blah. So if COVID viral load is high, then blood sugar control will be poorer, and those patients should be admitted in the hospital for good control.
Right, right. One question that's come in as well is, do you recommend, and this is for either of you, do you recommend use of blood glucose monitors, the self-monitoring and BP monitors?
Definitely, if a subject who is affected with COVID and at home, this blood sugar monitoring and blood pressure monitoring will be essential, and that not only once a day, maybe multiple times a day. And this blood sugar monitoring may be self-monitoring blood glucose by a glucometer, or we have certain other glucose sensors that can be put over the outer aspect of arm, and that can sense blood sugar every 5 minutes or 10 minutes. And the reading can be taken by a reader, just like a mobile like device can have the blood sugar monitoring. And if blood sugar is not under control, it goes more than 200, 300, 400, then my advice will be to get oneself admitted in hospital. Similar is the case for blood pressure. in COVID situation, what we are getting, blood pressure is going down, patients are having hypertension. As Dr. Rungta rightly pointed out, this hypertension is leading to kidney diseases and serum creatinine goes up. So if blood pressure is going down, those subjects will also need hospital admission for proper blood pressure control, may need intravenous fluid or saline or proper management. So this monitoring are essential.
Right, right. One question that's come in, and maybe Moina, after that, you can ask a couple of questions in Bengali. Does HbA1c affect creatinine levels post kidney transplant?
Right. It does. It does. As Dr. Rahman pointed out, the better the glycemic control is, the better will be the kidneys. So it all depends upon what is the glycemic control. This is actually HbA1c and the fasting sugars and the postprandial sugars that we usually do. This is actually looking on the sugar levels from different perspective, right? So HbA1c is, as we all know, looking on the sugar control in the last 3 months, something. And fasting in the blood postprandial that we do is looking at the sugar levels every day. So both needs to be better controlled. You should not be happy that your fasting sugars are good, but your HbA1c is 8.5 and 9, right? So this indicates that your sugar had not been under control for the last 3 months. You had a good control on that day of the testing with your fasting blood sugar, say 100 or something. So
Right,
the main target, I think, would be to have a better HbA1c control as compared to a fasting blood sugar control.
right, right. Okay.
One,
Sure.
Yeah,
I agree with Dr. Rungta, but one point to be kept in mind is that often these patients, these CKD patients, they are anemic. Their hemoglobin may go down. Their hemoglobin, sometimes we see hemoglobin 7 or 8 or 9. So sometimes HbA1c, that is the glycosylated hemoglobin, which is representing past 3 months average blood sugar, may come very good in the range of
yes,
6.5 or 7 or 7.5. But we should take that hemoglobin level of that subject simultaneously. If hemoglobin is low, then HbA1c will obviously will be low. And in CKD patients, if the patient is uremic, means not properly controlled, serum urea is relatively high, then this HbA1c assay problem may be there. So two things to be kept in mind. So one is level of hemoglobin and uremia factor. So sometimes this HbA1c may not be a proper representative of glycemic control for past 3 months. So you have other alternative also like fructosamine assay or glycated albumin assay. Although these assays are not widely available, but still we have to be kept in our mind that the limitations of HbA1c.
Right, right. Thank you. Thank you so much for your response on that. Uh, Moina, do you have any questions in Bengali?
আম, দুটো জিনিসের প্রভাব পড়তে পারে ডায়াবেটিসের উপর। একটা হচ্ছে যেটা জানতে চাইছি, একটা হচ্ছে স্ট্রেসের প্রভাব, মেন্টাল স্ট্রেস। আর আরেকটা জিনিস যেটা আমরা খুব মানে আম, আহ, এখন মডার্ন লাইফে লোকে ডায়েটিং এর মতো, যেটা একটা কিটো ডায়েট আছে কিংবা হাই প্রোটিন ডায়েট আছে, এই দুটো জিনিসের প্রভাব ডায়াবেটিসের উপর কিভাবে পড়ে?
রিগার্ডিং স্ট্রেস ব্যাপারটা আমি একটু বলি। আমরা একটু আগে বললাম যে স্টেরয়েড ইনডিউস ডায়াবেটিস, স্টেরয়েড কি করে ডায়াবেটিস করে বা কি কি বিভিন্ন লেভেলে কি করে স্টেরয়েড এফেক্ট করে গ্লুকোজ মেটাবলিজমে। যদি যদি আমরা স্ট্রেসফুল হই, স্ট্রেস লেভেল যদি আমাদের বাড়ে, আমরা যদি খুব মেন্টাল প্রেশারের মধ্যে থাকি, তাহলে আমাদের শরীরের এই স্টেরয়েডের মাত্রাটা অনেকটা বেড়ে যায়। আমাদের শরীরে যে ইন্ডিজিনাস যে স্টেরয়েড হরমোন কর্টিজল বলে আমরা জানি, সেই কর্টিজল হরমোনের মাত্রা অনেক বেড়ে যায়। যে কর্টিজল আমাদের ডায়াবেটিস করবে। আমরা যদি প্রি ডায়াবেটিস থাকি তাহলে আমাদের ডায়াবেটিসে কনভার্ট করবে, আমরা যদি নর্মাল থাকি তাহলে প্রি ডায়াবেটিসের দিকে নিয়ে যাবে। যে সমস্ত ডায়াবেটিক সাবজেক্টস আছে তাদের গুড কন্ট্রোল থাকলে তাদের পুরার কন্ট্রোলের দিকে নিয়ে যাবে দিস স্টেরয়েড। আর নাম্বার 2 হচ্ছে যে স্টেরয়েড আরেকটা জিনিস কি করে, ইট স্টিমুলেটস আওয়ার অ্যাপেটাইট সেন্টার। তো আমরা বেশি খাবো, অনেক সময় ডিপ্রেশনে বা ভীষণ স্ট্রেসফুল কন্ডিশনে আমরা বারবার খেতে থাকি। So that can also lead to poor control of diabetes mellitus. This is number 1. What is your second question, madam?
একটা ছিল যে হাই
High
প্রোটিন
keto
কিংবা
diet.
কিটো ডায়েট, এই
হাই
দুটোই
প্রোটিন এবং কিটো ডায়েটের ব্যাপারে আমরা বলি। এই কিটো ডায়েট আজকাল খুব বেশি চলছে, বাট আমরা জানি কিটো ডায়েটের যে কন্টেন্ট সেটা হচ্ছে যে টোটালি কার্বোহাইড্রেট লেস, অনলি ফ্যাট অ্যান্ড প্রোটিন আমাদের খেতে হবে। সেটা আমাদের ইন্ডিয়ান সাবকন্টিনেন্টে আমরা যে ডায়েট আমরা খাই তাতে অনেকেই আছে ভেজিটেরিয়ান, যাদের ক্ষেত্রে এটা একদম ফ্রুটফুল হবে না। যারা ভেজিটেরিয়ান নয় তারাও কিন্তু আমাদের ডায়েটের একটা বড় পার্ট হচ্ছে কার্বোহাইড্রেট। অলমোস্ট 50-60% আমরা কার্বোহাইড্রেট খেয়ে বেঁচে থাকি। তো তাদের ক্ষেত্রে হঠাৎ করে যদি কিটো ডায়েটে আমরা কনভার্ট করতে যাই, তাহলে কি হয় আমরা দেখি আমরা 1 সপ্তাহ, 2 সপ্তাহ, 3 সপ্তাহ, ম্যাক্সিমাম 1 মাস করতে পারবো, তারপরে আমরা আর পারবো না সেটাকে কন্টিনিউ করতে। ফলে ফলে আমরা কিটো ডায়েটকে আমরা রেকমেন্ড করি না। বা স্টাডি যদি আমরা দেখি সেক্ষেত্রে কিটো ডায়েট যে এই সমস্ত নর্মাল যে ডায়েট আমরা খাই বা ডায়াবেটিক ডায়েট যেটা অ্যাডভাইস করি, কিটো ডায়েটের সেরকম কোনো হেড টু হেড স্টাডিজ নেই যে কিটো ডায়েট ইজ বেটার দ্যান দিস ইউজুয়াল ডায়েট। সিমিলার ইজ দ্য কেস উইথ হাই প্রোটিন ডায়েট। তো আমাদের এডি আমেরিকান ডায়াবেটিস অ্যাসোসিয়েশন যেটা রেকমেন্ড করে যে কার্বোহাইড্রেট উইল বি অলমোস্ট 40-50%, then this fat will be 20-30%, and another 20-30% will contain protein. Regarding fat, আমরা বলবো saturated fat, trans fat to be avoided. তো আমরা যদি এরকম একটা ডায়েট ফলো করতে পারি, যে একটা ডায়েট যেটা অলমোস্ট 40-50% কার্বোহাইড্রেট, 20-25% of fat, which will not contain this trans fat and saturated fat, and 20-30% of protein, then that will suffice. We did not to go behind this keto diet and this high protein diet, which is not sustainable. যেটা আমরা লং টার্মে করতে পারবো না।
Right. We just got a question. Does chia seed and apple cider vinegar with lemon reduce blood sugar?
These are nowadays coming up, this apple cider vinegar and citric acid citrate with a lukewarm of water early in the morning will cut down obesity and will reduce blood sugar. There is no head-to-head trial of these things, but practically what we see, this apple cider vinegar has to some extent, it has the ability to cut down fat, it reduces obesity to some extent, but yet there is no study which concluded that of course yes it will be better for those who are obese. So no proven benefit, but still to some extent benefit is there.
I was going through one study.
Yes, sir.
I was going through very recently, I was going through a study about this apple cider vinegar, and what they've shown is, continuous morning intake for 5 months reduce the weight by 2 kgs. So I think it's futile. It's futile taking apple cider vinegar, and it has its own side effect. It's very acidic. The pH is very low, and most of the patients who are regularly taking it do suffer from gastric ulcer and gastric problems.
Right. Okay. All right. So I think we don't have any more questions from the audience. So let me quickly share my screen and so once again, I'd like to thank Dr. Rohit Rungta and Dr. Hammadur Rahaman for taking the time to explain the answers and the information in both English and Bengali. You've very patiently done that. So thank you. And for our audience who's watching, if you would like to contact them, the contact details are there and they can also be reached through the hospital site. Thank you, Moina, for helping, and thanking Biocon Biologics for supporting this session in terms of patient awareness as well. Yeah, and just for those of you who are watching, and if you would like to get some information on managing diabetes better, we do have a couple of free ebooks that you can download from our website, as well as one for hypertension. So just go to our website, patientsengage.com, and in the ebook section, you can download it. You just need to register for free. So thank you once again, everyone. Thank you, Dr. Rungta. Thank you, Dr. Rahman, and thank you, Moina. And thank you to our audience for joining us today. So
Thank you, ma'am. Yeah.
thank you.
Bye bye. Thank you.
Bye.